I really got into breast surgery because I started doing research in breast when I was a resident. And at that time I had a mentor who was the head of the breast service at Mount Sinai. And with him I published 6 or 7 papers during my residency. And then after I finished my residency, I was asked to stay on at Mount Sinai and actually work for the head of the breast service as a breast surgeon. Oh, a tremendous amount has changed. When I first finished my training, that was when the randomized trials came out showing that lumpectomy and radiation was comparable to mastectomy. And for many years, I was one of the few people in New York who was doing lumpectomies and radiation. So I ended up with a big practice of women who went to a surgeon and were told to have a mastectomy and then came to me and had a lumpectomy. And as you're aware, since then, the amount of surgery we do for breast has gotten less and less. At that time, we were doing axillary dissections. And now, in most cases, we only remove one lymph node from the underarm, the sentinel node. And the extent of surgery for things like ductal carcinoma in situ is much less than it used to be. And for ductal carcinoma in situ in particular, we don't use as much radiation as we did. Many women used to get chemotherapy if they had a positive node in the underarm, and we now have genetic tests to show that which of those women will benefit from chemotherapy and which won't. So many patients who used to get chemotherapy now would no longer get chemotherapy. The women who are young with breast cancer under age 45, even without a family history, generally get tested. But those who are over 50 without a family history, or if their family history is only relatives that are elderly relatives, then they're not being tested. So if you had, for example, a mother and a sister with breast cancer, and you were diagnosed with breast cancer at age 45 to 50, you would probably be tested, get genetic testing. But if your mother and sister both had breast cancer in their 70s and you're in your 70s, you probably would not get genetic testing. I think Breastlink in New York is definitely the way to go. The women who go to a facility where you have everything you need to make the diagnosis, particularly with doing the mammogram and the ultrasound and often the biopsy if something is found, all in the same day, having the biopsy result within a few days, and then being able to see the oncologist and the radiation oncologist and the plastic surgeon if necessary, all that is terrific. When you have a group of people, physicians who know each other well, who work well together, the patient gets an excellent result. Well, I think there's no question that the risk amongst different races varies. The problem with looking at ethnicity is that the diet among different ethnic groups also varies, and there's no question that the amount of fat in the diet influences the risk of breast cancer. So if you look at an ethnic group that has a low-fat diet, they're going to have a much lower risk of breast cancer. The whole diet issue is a big confound, if you will, for looking at the risk of breast cancer in different ethnicities. Well, generally, I really feel the oncoplastic procedure should be done by the plastic surgeons. Breast surgeons are not trained in plastic surgery. To be honest with you, even though the plastic surgeon is often doing a reduction on the contralateral side when I'm doing a mastectomy on one side, I couldn't begin to tell you how to do a reduction, okay? But in oncoplastic surgery, it can be extremely useful if done by the plastic surgeon because they can incorporate the lumpectomy into a reduction if that's what's indicated, okay? The limitations obviously are with that kind of surgery is at the time that you're doing the oncoplastic surgery, you don't know what the margins are. And occasionally you find out a week or two later that you have positive margins, but because everything in the breast has been rearranged by the oncoplastic surgery, you don't know where the positive margin is. And theoretically, those patients should probably be getting mastectomies. About 10 years ago, there are a number of papers that were, in a sense, critical of physicians treating the elderly with breast cancer because they had a tendency to treat them less aggressively than they treated younger women. And so elderly women less often got axillary node dissections, they less often got chemotherapy, they were less often treated with hormonal therapy. And and none of those papers actually looked at what the consequence of this undertreatment was. And everybody assumed that if you undertreated the elderly, they were going to do worse. But when we looked at our own patients, and about a third of them did not get axillary dissections, about a third didn't get radiation, about a third didn't get hormonal therapy. In fact, their outcomes were much better than younger patients. And that's because the biology of breast cancer in an elderly woman is completely different than it is in a young patient, and shouldn't be treated as aggressively as it is in a young patient. The biology of breast cancer in an elderly woman, for example, if you look at estrogen receptors is found on normal reproductive tissues in young women, okay? And often when a breast cancer arises from one of those tissues, it retains the estrogen receptors, gives us a way to treat the cancer. We can treat them with tamoxifen, which blocks the receptor. In elderly women, we can use a drug called arimidex that basically prevents the body from making more estrogen. And generally, think of it from the standpoint of a tumor cell. If you're living in a woman who's of reproductive age and there's lots of estrogen around, you really don't need a receptor to get estrogen. And so estrogen receptor negative tumors are more frequent in young women, whereas an elderly woman where there's very little estrogen in the bloodstream, you need the receptor in order to get the estrogen to grow. And so elderly women are much more likely to have estrogen receptor positive tumors, which have a much more favorable outcome, and younger women are much more likely to have estrogen receptor negative tumors, which don't have such a favorable outcome. Well, from the beginning, as I alluded to earlier, basically as alluded to earlier, I was a big proponent of breast conservation. At one point, we looked at patients who were treated by a predecessor of mine at Mount Sinai. And he was one of the first people in the United States, long before the randomized trials came out, he was one of the first people to do lumpectomies for breast cancer. And he really got started because he had a woman who was a physician who had a breast cancer and absolutely refused to have a mastectomy. And he did a lumpectomy on her, even though she had a relatively large cancer, and she did well. And so he became convinced that, particularly with patients with small cancers, not the large ones so much, but the real small ones, could be treated with lumpectomy. And this was in the days before radiation was used on breast cancers. And he ended up with more than 100 patients who had lumpectomies for very small breast cancers and no radiation. And they had, at that time, a very low local recurrence rate in the teens. Okay? And so he was convinced that breast conservation could be used in these young women. And that pretty much convinced me that even before the randomized trials came out. Well, I think with respect to breast health, most of the variables that influence your risk of breast cancer are not under your control. You can't decide at what age you're going to start having menstrual periods, right? And the later you start having menstrual periods, the lower your risk. And you can't decide when you're going to stop. The earlier you stop, the lower your risk. You can influence things in between, but it's difficult to decide to start having children at a young age in order to reduce your risk of breast cancer, although that would reduce your risk, okay? And then you can't control who your parents are, right? So you're inheriting whatever you're inheriting from your parents that influences your risk of breast cancer. The things that we know that do influence risk is how obese you are. Women who are obese definitely have a much higher risk of breast cancer. And if we can stay thin, reduce our calories from fat, that's really the only variable that we control. And if we can do that, then we'll reduce our risk. Well, I've kind of stayed with the recommendation that we should start in patients with no risk factors. They should start annual mammography at age 40. Certainly, unfortunately, we have patients who are even 30 or younger that obviously have never had a mammogram that come and have a breast cancer. So it's a balance of how much you're willing to spend to do screening, plus how much you're willing to expose young breasts to radiation in order to find these very early cancers, versus the lives you save by doing it. So, and I think that the crossing point, if you will, is really around age 40. That's when their breast cancer is not so uncommon, and mammography is reasonable to do because the breasts aren't so dense by age 40.